Okay, so thank you for coming. We're going to start. So my colleague, Michael Blackie, and I would like to welcome everyone to the 2018 Humanities Frontiers Initiative Keynote Lecture. Before I introduce Dr. Garden, our speaker today, I want to very quickly contextualize this keynote and the project that it comes out of. So this keynote is part of the Institute for the Humanities grant called Stories of Illness, Building Health Humanities Portraits for Medical Training. And the grant has enabled invited health humanities experts and UIC and Chicago area faculty to work together today to think through a new approach for health humanities education in health professions schools. Rebecca's keynote is the culmination of a full day of workshops. The approach we have been workshopping is called the Health Humanities Portrait Approach. And this is based on work funded by the National Endowment for the Humanities grant. And it starts with the premise that case-based health humanities education needs to be more humanities driven and therefore deliberately tied to the contextual, ethical, and affective aspects of illness experiences. The project sets out to lay the foundation for reinventing the clinical case by purposefully structuring what we are calling a portrait around a social theme rather than a diagnosis or disease. The health humanities portrait itself pairs a first-person patient narrative with humanities scholarship that unpacks and situates the wider social, political, and cultural forces the patient's story depicts. My colleagues and I involved in this, and Joanna Michael is my co-PI in that project, believe and hope that employing humanities perspectives through a health humanities portrait approach should help students be more attuned to the interrelatedness between bodies, history and politics, and social forces and culture that deeply shape patients' experiences of illness and of health. Dr. Garden has been central to this project and has spent many hours with me discussing the strengths and pitfalls of this nascent approach. And I take Dr. Garden's insights very much to heart because she's a prominent and very generous scholar in the field of health humanities. And that is one of the many reasons that Michael Blackie and I invited her to deliver the keynote address today. Rebecca is Associate Professor of Bioethics and Humanities and holds a joint appointment in Public Health and Preventative Medicine at Upstate Medical University in Syracuse. She earned her doctorate in English and Comparative Lit from Columbia University. Her work draws on fiction, autobiography, film, and video to explore various socio-cultural and ethical issues related to illness, disability, deafness, and healthcare. She has published in a variety of journals, including the New Literary History, Disability Studies Quarterly, the Journal of Medical Humanities, and Academic Medicine. Dr. Garden is Executive Director and teaches in the Consortium for Culture and Medicine, an interinstitutional and interdisciplinary organization that brings together faculty and graduate and undergraduate students from medicine, nursing, the humanities, and the social and basic sciences. She is also course director for a healthcare ethics course for nursing and health professions students, and serves on the editorial boards of the Journal of Medical Humanities, the Journal of Clinical Ethics, and Literature and Medicine. So I want to thank Dr. Garden for traveling all the way here to share her thoughts with us on navigating obstacles in health humanities pedagogy.
Thank you. Hello, everyone. I want to thank everyone who was involved in inviting me here. So Mark Kenwell, Linda Vavra, and of course, Sandy Sufian and Michael Blackie. Thank you so much for letting me be a part of this. So does anyone know where this image comes from? What text? Can anyone guess? Yeah, well, okay, so this is from, huh? Say it.
It looks like Huck Finn.
Absolutely. Yes, no, it's an illustration from Huckleberry Finn, from one of the moments where Huck and Jim are separated during their long journey. So there will be other images of navigating obstacles. I take these things a little bit literally. Okay, so to get started, you are wasting my time. The student pointed to the class handout and said, our learning objectives for class today say that we're learning about the clinical presentation of tuberculosis, the clinical presentation of tuberculosis. Why are we talking about all this other stuff? I was facilitating the discussion in the Ethics in Public Health course for first-year medical students. The course is case-based, and the case described an outbreak of tuberculosis that had occurred a few years before at a homeless shelter in our city of Syracuse. An epidemiologist who had been a key player in stopping the progress of the outbreak was assigned to join me for the session. And it was considered to be a great opportunity for me as well as for the students. But he was equally confounded and also voiced his concern that I was getting a little off topic, although he said it far more diplomatically. Then I wondered, am I making a mistake? Have I somehow led the discussion astray? The case was designed to teach students how to understand disease causation and to define epidemics using a socio-ecological model. However, it did not allow for questions about who becomes homeless in our city and why. The case was designed to teach students to identify risk factors for tuberculosis, but not to deconstruct the notion of risk and how it works in tandem with constructs like risk factors to reify and reinforce rather than analyze and reject the stereotypes and stigma that are related to racialized identities. The socio-ecological model, as it was taught, adhered to what is perhaps intended to be a simplistic visualization, of, I was supposed to acknowledge the NEH grant. So here's the most simplistic visualization of discrete concentric circles, where the sphere of the individual is distinct from the interpersonal, the institutional, and the community. Oops. And then public policy. So here are some examples of the graphic. This is from the CDC. This is a little bit more fleshed out. And some of these images show an arrow directing outward from the individual through the other categories. What it doesn't show, however, is the complex interplay between the social and the individual. So what's missing for me in the case, and what I was trying to interject with questions that were leading away from the learning objectives and the script that we were given for this case, was a discussion about the causes of the risk factors. Why were these particular people living in homeless shelters where they're at increased risk for exposure and infection due to crowding? Why were these particular people at risk for the underlying medical conditions, including alcohol and illegal substance use disorder? What is the role of race, class, gender, disability, sexuality? What is the role of naturalized forms of oppression, such as some of the language that was used, oops, I got one ahead. Some of the language that was used to describe the homeless men, even by the epidemiologist who was teaching with me, who actually referred to some of the men as a bunch of drunks. You are wasting my time, the student said. We're supposed to be learning about the clinical presentation of TB and how to address an outbreak. And the epidemiologist more diplomatically agreed, and I quailed inside. But I forged on and I even fought back. I told the student and the whole class that if they don't understand these critical social issues that shape disease and disability, they'll never be able to prevent the disease outbreaks. And I will just add as a coda that after the class ended, when I was wondering whether I had done the right thing, a student did come up to me and say that once he heard the other students saying that I was wasting his time, he had felt silenced, unable to participate in the discussion, even though he very much wanted to continue the focus on racialization and ethnicity and class. And he was a student of color, and the student who objected to my line of inquiry was white, and it may be that racialized power differentials were at work in the claims and the silences in the classroom that day. In any case, I was reassured that I had done the right thing in forcing my agenda on the case discussion. I had. And I followed up with feedback to the course directors about the case and the course overall, trying to explain in what was really too long for an email, but not really articulate enough as an argument, about what was missing from the course. And I would argue from the entire medical school curriculum, which is an education in the social determinants of the social determinants of health, the social factors that shape the transmission of disease and the experience of disease and of healthcare. So we need to educate our students about the fact that public health surveillance tracks not only diseases, but also health behaviors and the people who live with those diseases. So as a literature PhD who began grad school in the 90s, it's incomprehensible to me that we can use the term surveillance in medical school. We can talk about surveillance without even the slightest shiver of Foucauldian paranoia, let alone a groan of impatience with what seems like what is to us now an obvious critique. But we teach about lead exposure without teaching our students about segregation. We talk about health disparities, but we don't educate our students about the structures that shape them, the racism that leads to segregation. We don't teach our students about the history of apartheid-like differences in policy that have created segregated neighborhoods and disparities in housing, employment, education, food access, transportation, and wealth that contribute to disparities in healthcare and in health. The case-based approach and the socio-ecological model that informed it naturalized and reified these categories of difference and these disparities. And that allowed the student to tell the professor, you are wasting my time. And I'm sure there are more complex versions of this model. The question is, are they being taught and how? So the medical school curriculum as it's currently constructed is the most significant obstacle to the kind of education that I think students need to be ethical and effective practitioners. The health humanities portrait approach to medical education is a significant compass for navigating through that. The health humanities portrait is decidedly not a case. It is in fact an anti-case. And Sandy and I would both like your thoughts about this during the Q&A, but I think it's a much needed antidote to the focus on cases, diseases, diagnoses, and organ systems. And while it's easy to see how a focus on diseases can neglect pathologization and how a focus on organ systems can objectify patients, we may see cases as having the potential to be socially and morally complex enough. But at least as they're currently configured, I don't think that they are. We need a model like the health humanities portraits to teach what Helena Hansen, Jonathan Metzl, Dorothy Roberts, and their colleagues call structural competency. So structural competency is one approach to expanding the scope of healthcare education beyond cultural competency and even beyond cultural humility, which I think gets us partway there. Structural competency extends beyond the focus of individual patients, individual beliefs and behaviors, and beyond the confines of the clinic and clinical encounters to encompass the systemic causes of health inequalities. So Metzl and Roberts tell us that structural competency focuses on the policies that shape institutions and practices. This approach not only addresses the policies that influence healthcare as a delivery system, but also examines the way we define illness and health. The model of structural competency helped to orient my hunch that I needed to be teaching differently. So years ago, when I took over directing a course in healthcare ethics, I asked students to give me some examples of ethical issues involving justice as it was taught in that course, which was really distributive justice. So examples of dilemmas involving scarce resources. So some of the nursing students having years of clinical experience said things like, Yeah, here's a good example. These refugees just come here for our free healthcare. And this was before the Affordable Care Act. So I had to tell them to look up the definition of refugee, tell me where we had that free healthcare that was available. They would also say things like, well, we shouldn't be wasting our scarce resources on treating prisoners. So it was at this point that I realized I needed to start teaching students about naturalized and therefore masked benefits and entitlements that are accorded to some people and not others, and the naturalized and therefore masked ways that certain groups are disadvantaged and segregated from the resources and opportunities in our society. I learned about structural competency, and it gave me the arguments I needed to back up the new objectives and subject matter that I developed for the course, expanding the category of justice far beyond questions such as who gets organ transplants, or if there's an epidemic outbreak, who gets the ventilators or the vaccines, if there aren't enough to go around. So now I teach my students about social justice issues such as health disparities in the city of Syracuse. And not only that we have the highest number of African Americans and Latinos living in what's called extreme poverty amongst the 100 most populous cities in the United States, but it's also some of the reasons that we have such severe segregation. So I now teach my students about the history of the highway policy and urban renewal that led to the decimation of what was a thriving neighborhood of African Americans, Italians, and Jews, and how Black people who had once been homeowners and business owners were displaced into public housing and other rental situations through policies that created discrimination in housing and thus created disparities in overall wealth and thus health. Some of my students and even their program directors struggle to understand what this kind of education has to do with their training. They just don't see the connection. But Metzel and Roberts tell us that we cannot address inequalities in health and healthcare by restricting our focus to the individual patient in the manner of cultural competency. And they argue even cultural humility. Although I think cultural humility tells us we need to recognize the expertise in communities and be committed to advocacy in communities. But Metzel and Roberts argue that, quote, locating medical approaches to racial diversity solely in the bodies, backgrounds, or attitudes of patients and doctors leaves practitioners unprepared to address the biological, socioeconomic, and racial impacts of upstream decisions on structural factors such as expanding health and wealth disparities. I want to take the students upstream, where they can learn about how the history of salt mining and manufacturing turned our Onondaga Lake, that was once at the heart of the Six Nations of the Iroquois Confederacy and is now at the heart of our city, into a Superfund site. And I want the students to understand the impact that this has on the health of our communities. But you are wasting my time. I keep hearing that, not only in my head, but in course evaluations and in discussions that I have with students. And that obstacle threatens the whole expedition. So I'm just gonna keep going with this metaphor. Let's say this together. We're gonna need a bigger boat. I'm sorry I sprang that on you early. It was like, oh, I worked so hard on this joke. But I'm very anxious as a social speaker, and I was like, oh, I have a joke. So we're gonna need a bigger boat, and I found one, and it's one of those pontoon boats, and it has like music and snacks. It's the Health Humanities Portrait Project. And of course, it's in early stages. It's still a work in progress. And also, to be honest, I could not find an image of a pontoon boat with people on it that didn't involve only white people. So this was the best I could do, given the topic. So the Health Humanities portraits are mapping social issues. As a historian deeply engaged in social theory and a transdisciplinary disability studies scholar, Sandy Sufian is training our focus on what happens upstream. These portraits are not cases, and they do not address diseases, diagnoses, or organ systems. Each portrait has a set of learning objectives, but the portraits resist distillation into the bulleted sentence fragments of the PowerPoint slides that obscure agency and complexity in medical education. They resist the simplification of the mnemonic acronyms and reductive or redundant visualizations of data and the instrumental bioethics cases that strip away intricacy, contingency, and symbolism. Do I sound a little bit like frustrated with my pedagogical context? My own approach to adapting an existing case-based healthcare ethics course was to write new cases with social dimensions and then pair those with the first-person narrative and contextualize this paired case and narrative with critical readings. But the health humanities portrait deliberately excludes the case because this isn't curriculum teaching the social context of clinical ethical dilemmas. That's not what this is. This is a curriculum for teaching social issues. What this means is that rather than teaching clinical or ethical reasoning that focuses on drilling down to some specific approaches to solving a specific ethical dilemma or clinical problem, these portraits open up discussion about social issues. They create the context for students to formulate the questions that will help them to analyze and understand the upstream forces, the social determinants of the social determinants of health. In other words, social epidemiology, which is a critical studies approach to public health that I learned about from Sandy. So rather than talking about disparities in infant mortality by race, and comparing so-called risk factors of low birth weight by race, as I've been asked to do, these kind of table formats. This approach teaches students to ask questions about what might cause someone to drop out of high school and thus not receive a diploma, to not list a father on the birth certificate, to not have prenatal care, or to smoke or use illegal drugs during pregnancy. They can ask about and so learn about discrimination and access to education and healthcare, about mass incarceration, about the ongoing traumatic stress and the stigmatization that can contribute to unhealthy actions and practices, and that in and of themselves wreak havoc on health. Students will question terms like lifestyle and choice when used to describe people in heavily constrained circumstances. The scholarly readings in the portrait address the ways that lives and health are shaped by representation through language and culture, by expression and enforcement of norms, by public policies and institutional practices, and it will address the way that these forces have worked historically. In addition to the critical readings, there's a first-person narrative that is a major part, critical element of the portrait, and Sandy calls this the patient story. This is deliberately intended to be a counter-narrative, countering the genre of the case. Cases are generally fictional or at least written with precise instrumentality that often strips out rather than builds in the complexity of issues that the portrait's scholarly readings are designed to engage sui generis. Cases often privilege the physician or clinician's perspective and objectives. The patient's story, on the other hand, is the first-person account that represents the experience of those who seek health care and those who may never gain access to health care, much less contribute to its discourse, its various modes of representation. And while we know from the development of the field of health humanities, which is also called medical humanities, narrative medicine, and the ungoogleable literature in medicine, if you've tried, you get nowhere, among other things, we know from the history of this field that many of our narratives of the perspectives of those who seek healthcare enable the individualization of healthcare, and disability as much as any case does. So the criteria for selecting the narratives for the health humanities portrait includes that social issues are embedded in the narrative and that the critical readings engage those same social issues. The patient story is also a story of history, of language and images, of social and cultural practices, of institutions and societal norms. But that story is trash. I had wondered what was going on in my small discussion group that day. It was a little over a month ago now, and in the healthcare ethics course that I direct and that I revised over time, I now have a number of sessions on social justice. And in this particular session, I wanted the students to learn about environmental injustice from the perspective of people who are disabled and made chronically ill by the policies and practices that underwrite pollution. So instead of a case, I didn't have a case at all this time, I assigned 2 very short, accessible readings, because students are going to read that much. And these readings were on how structural forces influence health disparities. And I also assigned a first-person narrative called, it was an excerpt from what the author calls an environmental memoir. And in the memoir called Body Toxic, Suzanne Antonetta, which is the pen name of Suzanne Paula, describes spending her childhood summers with her extended family on Barnegat Bay, and this is in Ocean County, New Jersey. And this is near Toms River, so you guys might know about this area being notorious for environmental impacts. So in this memoir, the narrator searches her early memories and her childhood diary to find clues that will help her to understand the illness that she and other family members experience. So merging personal narrative with something that's more like history and public health advocacy, this narrative the narrator supplements her memory with research into what was a devastating amount of environmental pollution. I urge the students to keep in their mind while reading this memoir, keep in mind our own Onondaga Lake, which, as I said, was once the spiritual and cultural center of the Onondaga Nation and the Iroquois Confederacy, and later for the city of Syracuse, and is still in the process of being reclaimed as a from its status as a Superfund site. So in the lecture they had before we broke into small groups, I talked about health disparities and the way that mass incarceration and homelessness followed deinstitutionalization of mental health institutions in the 80s. And I talked about rural poverty and disparities in rural health, and also about environmental justice issues. And as I was writing this, I realized that's a lot to put into one lecture. So I definitely see how I need to kind of edit this project. But in any case, I met with my small group to discuss the excerpt, and I was really excited about it because I love this memoir. I love teaching this topic, and I came into the classroom and the conversation just was weirdly stilted, and half the class was unusually silent, and the rest kept skittering away from my discussion questions. I tried to ask them very specific things related to my technique, which is close reading. So I was asking them to describe the birds and the plants and the animals that Antonetta remembers, from her childhood in that area on the Jersey Shore. And then I asked them to describe the sources of pollution that she discovered in her research as an adult, which to me was fascinating. It includes a missile launch complex fire that took place and large-scale groundwater contamination with heavy metals and pesticides that happened in conjunction with a couple of different forms of manufacturing. And a few of the students turned the conversation and kept asking questions that eventually I could tell were trolling. So one student ended up asking me rather dramatically, "Do you believe in the deep state?" So granted, this was the student who came to class the first day wearing a Make America Great Again t-shirt, but there wasn't a whole lot of other stuff. This is like 2 months into the class. There had been nothing else. What was it about this memoir? I just kept cheerfully redirecting the conversation, but it wasn't till after class that I learned what was happening. That story is trash. A student who often talked in class and was uncharacteristically silent that day stayed after to talk to me. And she said she wasn't able to participate in the discussion because the discussion amongst the students before I arrived in the classroom was so toxic and troubling to her. And she said the students usually talk kind of lightly with each other about like who didn't do the readings, and you know, no one really usually did. But this time, one student said, that story is trash, and the others joined in. And there was just a general kind of surge of negativity triggered by this narrative. So this discussion in the group became so heated with scorn that by the time I showed up and just like unwittingly started the conversation, half the students were like frozen into silence. And the others were going down this kind of road of trolling. So I've begun to think through how this text, excuse me, and how the course's focus on social issues led to this kind of breakdown in sincere discussion and debate. And that's at least in my small group, because apparently this didn't happen in the 4 other small groups for this very large class. So I don't know how much to make of all this, but I do think that this particular text really bothered some of the students. It's extremely personal. The author quotes extensively from her childhood diary and minutely describes her memories of her family and the landscape where she grew up. She also, I'm sorry, my water's far away. Who is this like Marco Rubio? Was that the guy who did that? So it's a good thing it's not on Zoom.
It is on Zoom.
It is on Zoom. Oh, okay. So my Marco Rubio moment. So it's really personal. And then Antonetta politicizes all this intensely personal stuff, mapping out the potential for a correlation between her constellation of illnesses, which include manic depression, and the massive scale of contamination that leaked out of rusting barrels left in these open pits lined with plastic into these frond-like plumes in the aquifer. So that's another major obstacle for this kind of pedagogy. Even as I write this and talk about this now, I have more insights into how this kind of first-person narrative might have caused this sort of breakdown. But I also want to identify what I see as the challenges that might be posed by the political and social backgrounds of individual students, and I would add faculty. So there's a potential for backlash or some kind of resistance to or rejection of structural competency. This story is trash. You are wasting my time. So here I think of Delise Ware and Julie Altman's an excellent essay in the Journal of Medical Education that was published back in 2005 called The Limits of Narrative, Medical Student Resistance to Confronting Inequality and Oppression in Literature and Beyond. And I think of Michael Blackie and Erin Gentry Lamb's chapter in the Health Humanities Reader, which is called Courting Discomfort in an Undergraduate Health Humanities Classroom. The 2 articles describe similar obstacles and both draw on Megan Bowler's concept of a pedagogy of discomfort. And Blackie and Lamb argue for helping students to be, quote, open to the discomforting possibility of seeing familiar things made disturbingly unfamiliar, close quote. Many of us feel that the health humanities portraits pedagogy is needed more than ever at this particular historical moment, as we see this disintegration of hard-won policies and even of the institutions that with all their flaws promote health and well-being and provide health care. Because of the intensity of this moment in history, some feel that we should avoid politics, which I would argue is impossible in healthcare education, and which can result in abandoning rigorous intellectual analysis and debate. As it is, many medical students resist anything that doesn't prepare them for the step 1 exam, or to write a note, or to break bad news. They're immersed in memorization and how-tos. Excuse me. This approach is potentially disturbingly unfamiliar, but that's what it should be. If they're to take a metacritical perspective on the contours of those how-tos. So we want to get them to critique and problematize the how-tos they are taught to use. What shapes that kind of education? And how does it shape clinical practice? So as you can see from the do-it-yourself pontoon boat, this approach is in progress. We're working on theorizing it as we experiment with these workshops like the ones that we did today. There are many important questions that I invite you to ask and to help us to answer, especially involving resistance from both faculty and students. You are wasting my time. This story is trash. We are also just beginning to ask questions like, how can we achieve the level of rigor required given the strictures of time and the rest of the curriculum? How can we maintain this rigor if the approach is taken up by others with less expertise in this methodology, something we were just hashing out in the last workshop? Part of the insistence on rigor, thanks to Sandy, has meant that experts in social sciences and humanities are leading these workshops to train primarily social science and humanities faculty. This raises the question of whether it can be taught to and with clinicians. If so, what level of training in the social sciences and humanities is required for them to participate? What happens when we try to publish this in clinical medical journals? And just as a quick example, when I published in the Journal of Clinical Ethics a critique of empathy, I used the word power 4 times. The editor, over successive revisions, deleted each instance of my use of the word power. And I had to fight, and I was pre-tenure, to get that word back twice, 2 out of 4. How do we avoid being reduced to multiple choice questions, Likert scales, and otherwise bullet-pointed fragments of professionalism, measurements of empathy, and reductive approaches to cultural humility and implicit bias? With this approach, we hope to teach students how to ask questions. So please join us now in answering your questions, ask your questions, and I assure you, you won't be wasting my time. This is my next joke. Jericho, but this is my real question. Yes.
Question, so this is maybe a sympathy for the devil question. Those students shouldn't have come at you in that way or said those things. They are brutal, but I want to take them at their kernel of their confessions of honesty that I don't get why we're doing this, kind of take it at that level. And I sometimes think that you know, what you're describing is a challenge to the rest of the curriculum they're receiving, and you very much intend it that way. And so I sometimes have sympathy for students as like being children of divorced parents who are trashing each other, and they're bouncing between our houses.
Oh, that's such a good metaphor.
And we're asking them to choose.
Yeah.
And you know, if I'll just go by gender, if you're the mom who's trashing the way it is at dad's house, and they spend the majority of the time at dad's house, and psychologically that's kind of where their safety is, it's hard. And the ones that go with it, if we put ourselves in opposition to the rest of the curriculum or the medical model, and so while we're simultaneously asking them to learn to identify disease and treat disease, and all of us with bodies in the room think that's a good thing, and to go big and realize how completely messed up the system of you're about to go into is, and that's actually a lot, and it's not just because they're 23 often. That's a lot for me too, but I got a few years on them. So I just wonder how we can gently and with cultural humility for our students' culture and the challenge of all they're asked to know, and then to explode their cultural, political, social, structural paradigm, and do well on step 1. Like, how can we, I want to do all those things, but I wonder, I worry sometimes in this blaming the victim, that we blame the students for being narrow, and we don't turn to our colleagues in the other area of the medical school and saying, you are being narrow. I will take you on peer-to-peer power and power, because we need to integrate this.
So I will say, first of all, that medical students, like children of divorced parents, are very good at compartmentalization. So I think they're far more resilient than sometimes we give them credit for. And this was actually portrayed to be a critique of the curriculum. So that example, excuse me, that example was in my, oh, that's not mine, I'm relieved. That example was in the part of my talk that was about the obstacle that the curriculum poses, because the focus was about the fact that there was nowhere in that set of learning objectives what I felt was my ethical obligation as a professional to teach. And so I was trying to force an agenda. And then, you know, I described following up with course directors. It hasn't changed a whole lot. It's actually, we have moved away from those handing out, you know, these handouts literally in class of the tables of risk factors and low birth weight and infant mortality by race that I felt were incredibly harmful given the lack of contextualization, let alone a broader critique. So really I'm not blaming the student, I'm blaming the curriculum and naming it as the key obstacle. And that I think you're absolutely right that there are going to be students who, because they don't have the broader context that that other student did, who came up to me and said, I wanted to keep talking about race because it's something he doesn't have the privilege to ignore. So he sees the connection, right, between race, homelessness, disease outbreak, and disease management and surveillance. So I think we need to find a way to teach across that perspective, and that's what this project means to do. The thing that's complicated is, will it ever become really interwoven with the overall curriculum? Because as someone pointed out in one of the workshops earlier today, there's no real coherence in the overall curriculum anyway. How many schools, at least not at mine, they didn't like have this idea, we're gonna create a curriculum and do it from the broad view and then drill down. It's basically patchwork. So there's a hand up.
Can I respond a little bit?
Yeah.
Okay. I don't know if I should stand, but two just quick points about this. I don't see this portrait approach as an either or. I think that the clinical case is constructed in a way, in a specific way for specific reasons, like to test and develop clinical reasoning skills. And it's fine. Like, that's great.
Oh yeah,
So
I didn't mean to imply that.
It's not an either or. And the conversations that we've had and sort of the positioning of the portrait as an anti-case, right? Mm-hmm. That's sort of between us as scholars and sort of the theoretical positioning of the approach. But the students don't need to know that, and I don't think it should be pitched to administrators that way either. It's not an either or. It's doing different things. It has different. It's a vehicle to do different things.
And I would even
I wanted to.
I would even say the reason it's helpful for me to think of it as an anti-case is because I'm so case-oriented. I'm so narrative-oriented, right? That I have to resist that individualization myself. So it's a really helpful sort of, that part of what Sandy just said is a helpful shift.
So the other part of this is how do we integrate this into the regular medical school curriculum? And I think that is a challenge, and partly I think it's a challenge because, at least right now, I would like to insist on this not being framed around disease. And medical school curricula, I mean, we have the reproductive system, block, and we have the, renal block, and so the way it's all constructed is around a disease. So when I was, is Joanna here or did she have to leave? Oh, when I was first discussing this with a colleague of mine in the department, she was like, oh, you know, this is wonderful. Let's integrate it into the regular block system. And I said, okay, great. And she's like, okay, so, you know, where do you think you would put this portrait that you're proposing? And, you know, would it go in the cardiovascular block? And what disease does the story, you know, reflect? And I'm like, oh, no. This is not about a disease. I don't want it. Once it goes into that system, it becomes about the disease and not the social issue. So what we've decided, at least here, and we'll have to see how it works out, is, you know, it's not the best, it's not ideal, but in order to maintain the integrity of the social issue over this, you know, slipping into about a disease, we're doing it in these sort of seminar that we call medical colloquium. So, you know, whether or not that's the best way, I don't know, we'll have to see. But yeah, there's that tension of like, how do you integrate this? Because the curriculum is so much about, the whole thing is framed around and organized around diseases.
So I think Matt and the person behind you, and then, I don't know, Mark, if you were going to say something, you were starting to. Yeah.
So I wanted to add in, thank you very much. I wanted to add in, you mentioned Metzel, and there was a lot of discussion of Metzel earlier. And I think one of the things that makes it hard to think about structural competency and then integrating that into med or other health professions curricula is because what Metzel set up is an undergraduate degree program and a master's degree program in which students spend however many years learning about these things, and then they go off to med school, and then they were already set up ready to be able to handle the clinical stuff and knowing all the social structural things. And yeah, that's really hard to try and figure out how do you get all different pieces.
Yeah, I think, I mean, I've never had more than like an hour in the medical school curriculum to teach disability studies, like to teach everything related to disability justice, disability studies, and then they took it away. I don't even have that anymore. So I just kind of feel like whatever little wedge you can get, and the question, there's always a good question about, should this be required so that it's respected? But then you have people hating it and kind of poisoning the whole discussion. Should it be an elective? Let that tiny number of people who get it disseminate and let 1,000 flowers bloom, or 1,000,000, whatever. I don't know. But it's like, it's really, these are really good questions, and we'll never get that much turf anyway. So I think it's better to be sort of surreptitious about it behind that.
I'm a student at the and medical humanities are very near and dear to my heart. I have a personal problem with the word compliance, and I think that this might read well in this room, that compliance is not a great word to use. And when I have questioned that in a pathophysiology or pharmacology lecture, you use the word adherence, because that's more of a collaborative improvement with our patient. How do you see how students can challenge that power in that center? So we're having this conversation about curriculum and the peer-to-peer conversation. How can students challenge that through this sort of portrait framework?
So I think this is such an excellent question, and I would even suggest that adherence has already taken on the stigmatization of compliance, because as long as we continue to stigmatize patients and see them as, you know, needing to be obedient to physicians' orders or providers' orders, it doesn't matter what we call what they're supposed to do. It's still going to be representative ultimately of that power differential. So that question, that power differential exists in your classroom too. but you actually have a lot of power as students, and you're kind of branded as consumers. So there are ways that you can organize with other students to say you want to do an audit of the curriculum. And this might mean taking on an additional burden. You want to just do your studies and do the best you can, but it is something you can put on your CV, but say you want to do an audit of the curriculum and just identify where in the curriculum might be a good place to integrate some of these structural approaches, or to identify some of the terms that sort of participate in these the oppression of patients, and how this might be a good area for faculty development or course or curriculum development. And if it's part of something that's sort of offered as like, here's the gift to the curriculum committee or whoever oversees your curriculum, that could lead to something good. I don't know, it depends on how good your school is at responding to that kind of insightful input and really caring about it, because it takes a lot of effort. A lot of faculty may resist this kind of approach because it's unfamiliar to them. The pedagogy of discomfort kind of encompasses faculty as well, who will be made uncomfortable by this, by their students having more sensitivity about being more woke in a fundamental way than they are. So it's, I can talk more about it later. Did you want, you're like.
You are such a great reader of faces. I didn't even have to raise my hand. This is coming from not hearing your discussions at all, but just hearing what you've been talking about right now, and also what Sandy was saying. I was wondering if you could say a little bit more about the degree to which this is about a critical thinking about social and political structures that you're encouraging, because that was almost what I heard Sandy saying. But then when I hear you talking at other moments, it sounds as if it's not just that you're saying we should think harder about social and critical structures, go do your critical thinking about that, but rather that you do want to invite some kind of discussion about what the overriding political structures might actually be. So you start to, well, I mean, is there some kind of theoretical commitment to where race intersects with class, for instance, or where does sexuality intersect with these different systems of hierarchy and relationality? How do they all map onto each other? And one could get into like really kind of big theoretical debates about which dominates overall or which dominate. I mean, I'm surrounded by people who say that one predominates over another. So I guess then the question is then, is it general critical thinking, or how committed are you to actually thinking about which, what is the general map of political and social structures that you would like students to see?
But I don't know if you would ask that question of any other person proposing a kind of curriculum, because you would have as many maps of the sort of political and cultural issues as you have faculty, right?
Yeah.
So there doesn't need to be one. So yeah, it's about opening up the students' minds. So these students are, and you guys correct me if I'm wrong, you have maybe a humanities background, so you are kind of bringing that, that's why you're here, right? Most students are coming in with basic science and math and not very much economics, history, sociology, literature, not much in terms of analyzing texts, analyzing representation from the scale of language to political representation, who stands for whom, right?
Yeah.
So just getting them in any way, right? It could be through any disciplinary lens to begin to do that kind of work is going to open up, I think, a lot of potential. But then it's really up to the individual faculty member who has some kind of disciplinary, you know, expertise and authority to sort of figure out, well, we're going to be focusing on intersectionality in this particular way. I wouldn't pre-select that. I don't see anything as necessarily, because that's all going to be, that's what we're debating about just amongst ourselves. And if you have a different set of faculty, you need to have a different set of debates about a different set of theories.
Yeah.
Does that make
Right.
sense?
It does seem as if you wouldn't like it if you had a good old-fashioned bourgeois liberal. You know,
Well, you're seeing my bias in how I teach the course, but I don't think that means that only someone with my particular, you know, politics can teach this course. Yeah. So we can talk about that in a more fine-grained way, and you can give me examples that put pressure on that. I think it was Ellen and then Craig.
I just wanted to return to a question that was kind of raised by the two people sitting and I was wondering about ways that this approach can, something that I wondered in my own school is whether this is in some ways more appropriate or an easier sell at the resident level, because and the other thing is to say these are the ways instrumentally that these ideas will help you, because all the problems of society walk into the emergency room, right? And so if you don't understand the complexity of the patient, rather than just say, oh, a complex patient, it's actually a way to combat burnout and to empower the physician to have better understanding of where this patient is coming from, to think about a more constructive way of supporting that patient. And you know, something that's happening in family medicine is, which is my department, is a lot of collaboration with public health and a lot of sort of like studies of people that are calling 911 a lot, and then sort of thinking about ways to address some of their issues and anxieties and conditions, and why they're first studying why they're calling 911, and think about ways that those needs can be met in other ways that don't involve taking paramedic time for those issues. And so that maybe at the MD student undergrad level, they're thinking about how can I pass the test? How can I pass my boards? But then they get to residency and they're like, oh, you know, how's this work? This isn't really working that well. And there was another, you know, there's also the question of the effective intervention. So in Milwaukee, where I used to be, there was a physician that told me she was part of a maternal and infant health public health initiative, and they came to low-income African-American women and gave them these sort of packets of things for the baby to assist them. And because they didn't understand socioeconomic issues, like they come back to check on what's going on, and a number of things were not being used because they didn't have enough money to pay the electric bill. So you don't really need that little plug to put in the outlet. And there were a number of things that required refrigeration, so they don't have electricity, they can't refrigerate. So there are sort of the presumption of a certain socioeconomic status, and then, you know, evidence-based medicine assumes that we're all at Northwestern and we all have all the,
Right.
you know, the meds and the, you know, it's all the best scenario, and the patients are all interchangeable. And so, you know, in some ways it's, and that the clinicians are in revolt in some ways against EBM, because they're like, this just doesn't work. Like, this doesn't help me. Like, I need to deal with the person sitting in front of me. And so I wonder if there's a way to sort of have a, you know, availability of this at the resident level. That's my thinking.
I would say, I think that, so I actually argue we should be teaching these things in that K through 12, like at least a high school curriculum. Like, how can we not, you guys laugh, but how can we not teach this stuff? Okay, good. How can we not teach this stuff? Because it's about, all the time I think, what am I doing focusing on the curriculum and publishing these journals, I should just only be doing patient activism, right? Why am I wasting my time doing anything but empowering patients? But we should be educating people as young as possible about how to advocate for themselves in these incredibly complex, mystified systems, right? But undergraduate is probably a good place to begin. Maybe Craig will talk about that. And then to have it throughout, and maybe it's more intensively engaged. But I think one thing that came up during the workshop discussion, this has been the case for me, doing what are woefully inadequate, I call them extravaganzas. I've had these standalone interprofessional, that was how I got the time in the medical school curriculum, was by saying, I'm gonna do interprofessional education. So it's an interprofessional community workshop. I have people from the trauma response team in Syracuse, so people who are most affected by neighborhood violence and trauma in Syracuse, lead this session, and another session, it's refugee health. There are 2 new Americans. One is now a ASL interpreter in the medical system. The other is a physician assistant. Both were refugees. They lead these sessions. There are these huge sessions with over 200 students and faculty divided up into like 30 small groups. It's kind of like at the level of most students are like, wow, I had no idea. I had no idea there was so much homicide in Syracuse. Or if they knew, they had no idea the more finer grained issues of what that's like. But it's 2 hours. It's just this tiny little thing, but it's experiential. I guess I think of it as like Gestalt education, and it does, I'm not gonna use that word touches something, but it does ring some kind of chord where they feel like there's something real happening that connects with why they came into healthcare, unless they really were pressured by their parents. And a lot of them were, but they really feel like, and so if you can just have some of that, but then add more, I feel like there's not a lot of critical apparatus in that kind of event. Like I feel like the learning objectives are pretty simplistic, but if you can keep that going throughout the medical education, and then maybe, yeah, go deeper into it in residency, you know, turn the students into advocates. So Craig, I don't know what you were gonna say.
Yeah, so as many of you know, I'm curriculum at Paul University, formerly at UT Health in San Antonio, where it was the medical school. And we had a center for bioethics and humanities, which no longer teaches either of those things. So, you know, part of the problem was we kept getting squeezed out of the curriculum. So we had a 2-week 4th-year course that the students hated. It was the end of the 4th year. What's the point? And so that got dropped. And then we went to an integrated curriculum. And suddenly it was exactly as you described, Rebecca. It was, you know, which organ system should fit in, or it's going to be between modules looking at organ systems. So
nice.
where the interstitial tissue together. And you know, the first week was like amazing. The students were excited. They were interested. They were so ambitious. And then we saw them 6 weeks later after they had their cellular, and it was like the zombies entered the room, and you're wasting their time.
Yeah.
You know, the story is trash, and you're not supposed to be there. And what I realized at that point was it's too late. That we socialize these students through, you have to have this heavy science curriculum, and you have to pass these science exams. That by the time they've gotten to medical school, they've self-selected or adopted that self-selected way of thinking, that this is the only way this is the way I have to be. And so now I move, and I'm working with undergraduates in a interdisciplinary health program where the students aren't like, I don't need this is garbage. They come up to me and they go, what do I need to know? What does it mean to be a person in a health profession? And we don't emphasize doctoring as much as all the health professions. And so they're really into it. So I had, you know, 20 hours a week for 6 weeks. So we had, it was a lot, 180 hours over 4 years, 120 hours over 4 years, excuse me, which is way more than any other med school on the planet. When I left, it's not there anymore. And now I get them for multiple classes at 45 hours a time. So, you know, we can do so much more, and they're in the beginning of thinking themselves an adult and professional. We've adopted what I call the 360-degree view of health. So you look at health not a body part, but you have a condition in the community, and you look at it from the biological and the clinical, but as well as the economic and the social and the lived reality and, you know, the historical, and just put it into context. And what the other piece I wanted to put onto this was, so I can tell you that I know that the place in the curriculum in med schools for the humanities is shrinking. I had a piece come out in the JMH in December, and I surveyed every MD and DO school in the United States. I had like a 74% response rate. And if you look at the AAMC percentage of people saying they have medical humanities, it's decreasing the last several years. Except for 10 schools in the US who all have claim they have over 100 hours. The average school in the United States over 4 years of medical school is 24 hours total. And the comment I had from the overwhelming majority are integration is ending us and clinical ethics is ending us. Because what used to be time for humanities is now time, not for philosophical ethics, for clinical ethics.
Yeah. And yeah, and I just want to make sure you know, I don't argue with students who see that and do what's necessary. I have a colleague who's has a master's in anthropology and a master's in clinical research, and said she couldn't do any of that until she passed step 1, right? So it's not the students, it's the curriculum, and the students are the ones who are going to get stretched to do these like acrobatics of going from one mode to another. Anna Marie, and then you had a hand up. Oh, okay, sorry.
2 more, that's it.
So much fun. I just feel like until there's like only one person left in the room, I'll just get done.
Speak to the resident level, so that's what I'm trying to get started right now. And my background is as a medical student and then internal medicine resident, and now as a practicing intern at UIC. So I feel the time pinch for sure as a practicing physician and trying to also be involved in this stuff. But I've gone to the program doctor and tried to ask, like, can I do this with the residence program? And the time crunch at that point is very intense because not only do they have clinical responsibilities that are 80 hours a week, restricted to 80 hours a week, sometimes beyond. And then they also have to pass boards.
Yeah.
Right. So they have, so it's intense, but I think the need is so important because it addresses that burnout. So a lot of what we do in the M4 class is talk about physician narratives. And so what the physician brings as a physician narrator. And it's really interesting with the M4s to talk about that. And that's my goal to talk about that with the residents, because they get, like what I was saying, they're indoctrinated in this culture where they're not really humans anymore. They're just doctors. And so it's a really interesting, I think there's a big hole for sure. Too, but I think it's too late by the residents for sure. So I agree with all kindergartens. But I think there needs to be an opportunity for it with the residents. So I mean that's big. I would be interested in the survey about doing like 25 minutes in like 3 years of residency program survey. But I think it's necessary.
Can I step in on that? So when I proposed this, I was talking to a brilliant guy in our department, Alan Schwartz, and he does a lot of residency stuff. And that was the first thing he said, like, this actually is probably better for residents. And I said, okay, but I don't know if NEH is gonna fund that. You know, I need to get a grant and money to do the steps. So it's definitely a consideration for the next step of the project. I mean, there's lots of next steps, I think. But you know, we've talked about doing a summer institute. But you know, we're just way beginning of things. So, yeah. But I think it's true. It might be a good option.
Hi. I'm actually from nutrition. I'm on faculty in nutrition. I'm one of the directors of the M1 students with our nutrition students.
Oh, great.
So my question is actually more about if I contextualize the problem, because this is exactly what we deal with over in the Department of Nutrition,
how we can then start affecting change. So for example, we've all just kind of referenced, I actually have a job there because students couldn't write. They didn't know what I gave a whole lecture one time talking about subject, verb, object, and a student raised her hand and said, we don't know what you mean when you say subject. And so I teach grantsmanship and process of writing in applied health sciences. And it would drive me crazy because I would be asked over and over and over, could I just have your slides? Could I just have your slides? Could I just read your slides? And my English major heart would just break. And I didn't understand it until I had a middle schooler who does all of her homework as slides. So the grade schools, from grade school, middle school for sure, they're taught to read only slides, they're taught to write only slides. So we've started partnering with School of Ed to sort of say, we're not saying all of your students will become physicians or practitioners, but we really hope that perhaps they're better patients, to kind of contextualize what's happening. The other side of this coin is, and this is something I just came from a meeting talking about, is when we sit down to do teaching assignments, we teach like a disease. We look at who's covering this, who's covering that, who's covering obesity, who's got diabetes right now, who's got this, because the granting agencies force us to do research tied to disease. So while I believe in all of this, I wonder if there's any way to kind of circumvent I don't know what to do about that granting. If the money is tied to that, how do we then hire people who can then teach something other than the disease?
Oh, wow, that's so complicated. So setting aside the whole, and I will just say, I think writing is a way of developing a thought process that's really different from bullets on a slide. And the idea that, I also thought you meant the way courses are handed off one professor to another, and they're like, oh, here are my slides, teach from them. And it's like, here are my clothes, wear them. I just like, well, how the hell would I do that? I don't know what that means. The idea of obesity, for example, is like the code word needed to get funding, and you can get tons of funding in landscape architecture, in humanities connected to public health, and so if you have a critique of obesity, how do you contend with that? I think everything we do as humanities and social scientists in the context of medical education is like some kind of workaround. And the one thing I will say, there's just like this looming qualifier to everything I do, which is like this article that was published by Michael Taussig, like back in the 80s or something, something consciousness and the reification of the patient, where he basically says, if you're in a medical school, a healthcare institution, and you're trying to do this subversive stuff, none of it matters because it will be absorbed into the system, and it will just make the physicians and other practitioners and the people running the system better at managing and disciplining the patients, right? In that Freudian sense. So there's always, okay, so that's just like the big qualification, which I can now close my computer and leave because nothing I do matters. I'm just gonna go do those patient advocacy, like street demos. Direct action, that's all that counts. So having said that, I think you just have to work around it, and to know that then everything you publish with the word obesity is like incredibly problematic for anyone who's yearning for fat positivity and health at every size, and is stigmatized by weight discrimination in a way that's actually more physiologically as well as psychologically harmful than many diseases. So, I mean, it's a huge challenge, and I think there just has to be some kind of double consciousness, not to really too problematically, that's probably problematic to reference that, but it's double think maybe is a better term for working around that.
I'm from the College of Nursing, also background in humanities, and just wanted to say we've been going back and forth a little bit in terms of terminology, talking about literature and medicine, medical humanities, healthcare education, healthcare humanities, and I think much like the whether we're talking about adherence or talking about compliance, the language is important. And in addition to starting at an earlier age, I think the more interdisciplinary work because we all bring a slightly different perspective and understanding. And if it's just medical humanities, then you are stepping at the phase and you do have a power differential. If we talk about healthcare education or healthcare humanities, it broadens it. And I'm sure it's true at most institutions. It's certainly true here at UIC, where we in nursing don't know what you in medicine are doing in terms of humanities, but we are trying to do the same thing with our students. And if we all talked together, we would have, I think, a much fuller picture.
That's such a good point. And I just want to say, so I kind of cynically said, you know, I called this session Interprofessional Community Workshop because I really did know that that was the wedge I needed to get into the curriculum, but that I do see the hierarchy amongst team members as something that maps onto the bigger social hierarchy, right? Those kinds of issues, power differentials. And so that is a way, I think, to work across those differences. And in my institution, so we have a College of Medicine, a College of Nursing, College of Health Professions, and a College of Graduate Studies. The College of Medicine is like at the top of the heap, and everybody else, you know, gets like the crappy old buildings or whatever. I mean, it's like the distinctions, the hierarchy is really severe. And there are also real class differences, not, you know, I don't want to be monolithic about these different colleges, but there are real class differences and regional differences as where the students are from, how much they're working full time while taking their education, involved in their education, whether they're taking care of kids and aging parents while working full time, while taking a full load of classes, all that stuff. So I think interprofessional really is the right way to look at this, because it may be something that would take root more in other disciplines, other kind of professional training in different ways. But yeah, it's a really, but it is also a way to kind of work strategically and say, if we don't already have something interprofessional in the curriculum, this is the perfect area to, you know, and you can use, like you would use obesity to get a grant, you can say social determinants of health. You can say what would be the other kind of code term. It's social determinants of health. You can use cultural humility. These kinds of terms that are going to work like that buzz term to create recognition, right? Professionalism is a perfect example. And then really be critical about it, and you'll have to clarify that, you know, at the same time, right? It's that double thing.
Can I just quickly follow up on that?
Sure.
So there actually is this bigger whole conversation about the term, right?
Bye, Ellie. Oh, good.
There was an article called Health Humanities, the Almost Right Word by Tess Jones and Denise Ware and
Michael and Rebecca.
And and now we have the international movement is towards the term health humanities. So we have a health humanities consortium in the US, which I'm talking about. There's one in Canada now, and there's one in the UK, which is sort of pan-Europe. And the point of this is that, as you mentioned, it's not just about medicine. And the humanities should not be the handmaidens to the doctors. And so this movement, we're having these stilted and difficult conversations with doctors. We just had a very, I think it came out well, but it was a tough one over a month with Duke about these very same things. And we'd love you to be part of it. But health humanities is where it's the term that everybody's using.
And I think that this portrait approach, hopefully, can translate across health professions pretty easily, because it's really it's about the patient front and center, and not about the type of provider that's giving the care. And sometimes, like today, you know, we had a portrait that like there is no physician really in it. It's you know, and then Ellen asked the question: Are these people even patients, right? So I think it's flexible enough, and that's why we invited people from the College of Nursing to participate today, because we want to expand this notion, or at least practice the health humanities. So, thank you
Thank
so
you.
much.
Thank you.
Thank you, Rebecca.